Can I start the class? It's already 6:36.
Yeah, you can start the class, ma'am.
Yeah. Hi guys, this is Dr. Sushma. I am an MBBS doctor with an MSc in clinical neuroscience degree, and I'm your anatomy educator at the Oracle. And today we will be talking about the osteology of upper limb. I hope you found my previous class useful, and I hope that you could understand the limbs, nerves of upper limb. And today we'll be talking about the bones, right? Yeah. We at Oracle offer live classes, recorded sessions, notes, and MCQs. These live classes are very useful to keep you guys on track because when you're preparing for the exams, it's very important for you to stay on track. And these live classes, this 1.5 hour sessions, whatever we do, are extremely useful so that you spend this 1 hour in the evening doing something useful and learning something new. And if you still haven't understood the topic, you can always go and watch the recorded classes. You also get amazing notes and MCQs, which are based on CBME curriculum. And the MCQs particularly will help in the upcoming next examinations. And like you can use my promo code Dr. Sushma 20 for any kinds of discounts on subscription. And we offer a personalized counseling sessions as well, right? This personalized counseling sessions will be tailored for you alone, and we'll analyze your strengths and weaknesses, and then we make sure that these sessions will be of extremely useful sessions for you. And if you're finding exams and any kind of overwhelming thoughts in your mind, you should definitely go for these personalized counseling sessions where you will be given a mentor and who will make you understand not just the topic but also whatever the support that you need to crack your examinations, psychological support, notes and doubts and anything. And I strongly recommend you going for a personalized counseling sessions if you're finding first year overwhelming and not able to understand anything, right? So this is our tentative schedule wherein we have classes every day from 6:30 to 7:30 p.m. up until the 27th February. We are doing upper limb, and I'm sure towards the end of February at around 27, 28, we'll be confidently be able to finish the topics of upper limb, and these topics are extremely important for your examinations, and we'll be having very quick revisions. And I hope and to finish upper limb by the end of this month so that we can go on to the next topics, and I'm sure these classes will be extremely useful for you. And today's topic is osteology, right? Now guys, osteology per se, if you look at the topic, is not very important for you in theory examinations, right? In theory examinations, you will get one or two questions. That's it. You will not get many questions when it comes to osteology. Maybe they'll ask about describe, lower end of humerus, or just they'll give clavicle as a bone and they'll ask you to describe it for a 5 marker or a 3 marker question. But shoulder joint is an extremely important topic. But osteology as such is not a very important theory topic, but osteology is extremely important in your practical examinations. And I'll tell you how. In your practical examination, you will actually have a teacher who will sit with a set of bones, and you will have to go to the teacher and pick up a bone, and you'll have to answer questions, right? So that is why osteology can decide whether you pass or fail in your practical examinations, right? So quick tips when it comes to osteology in your practical examinations. Tip number one: always pick up a bone that you are comfortable answering questions, right? Let's say you haven't studied clavicle at all. Don't go and stand in front of teacher, and when the teacher asks you to pick up a bone, don't pick clavicle. In that moment, we get so stressed out in the practical examinations. We just don't know. We just pick up whatever the bone that is there in front of me. I'll just pick it up like this and see. Don't do that. Day before the exam, decide which bone you are comfortable with. Always, right from today itself, decide that, okay, this is the bone that I am comfortable with, and this is the bone that I will pick up in my final practical examination. So decide what is that bone that you will be studying and pick it up today itself, right? Start studying about that bone from today itself. So when you go to the practical examination, just pick up that bone and answer questions. Tip number 2, never get the identification of the bone wrong. What happens when you get the identification of bone itself wrong? Then the teacher will not have any interest to ask any further questions. Even though you may be knowing a lot about that bone, but if you identify the bone itself wrong, there's no point in continuing the viva and you will fail. So identification should never go wrong. Tip number 3, always identify the side properly, right? Whether the bone belongs to the right side or the left side, you should always identify the side of the bone properly. Otherwise, you will fail in your examination. These are some simple tips that are useful while studying osteology. Number 1, pick the bone that you're comfortable with. Number 2, never go wrong with identification. Number 3, never go wrong with identification of the side of the bone, which is extremely important. If you go wrong, you may fail in your exam. So osteology, not so important for theory, but extremely important for your practicals. Okay, now let's just take a small clinical case scenario in which we have a 25-year-old male who presents with pain and tenderness in the lateral epicondyle of humerus. Which bone is most likely involved in this condition? So we have radius, ulna, humerus, and scapula. I'm quite sure by now you would have already guessed what the answer is, but we'll still answer this question towards the end of the class. He is just presenting with pain and tenderness in the lateral epicondyle. So it most likely is looking like fracture. Pain is there, tenderness is there. So we'll see the answer towards the end of the class. I'm sure you know the answer already, but still we'll see the answer at the end of the class. Okay. Now, this is how the bones of the upper limb looks like, right? These are all the bones. First, you have the shoulder girdle. In the shoulder girdle, two important bones, clavicle and scapula. In the arm, you have humerus. In the forearm, you have ulna and radius. In the hand, you have carpal, metacarpal, and phalanges. Out of these bones, clavicle, scapula, humerus, radius, and ulna are extremely important for your practical examinations. You will be given one of these bones. Either they'll give these bones in the spotters or they'll ask you these bones in the osteology section in your practical examination. Okay? Yes. Now, let us start with scapula. Scapula is the shoulder blade. This bone is also called as shoulder blade. This is a flat triangular bone that lies on the posterolateral aspect of the thorax from second to seventh rib. Look at the shape of the bone, guys. This is a triangular bone that lies on the posterolateral aspect of the thorax, right? Now, since the shape of the bone is triangular, so obviously it is going to have three borders and two surfaces and three angles. So this, imagine the scapula, look at the scapular bone and it is looking like a triangle. So it is going to have three borders. The first border that we have is the lateral or the axillary border where I am pointing my mouse at, right? This is the lateral or the axillary border which has the glenoidal labrum and the glenoid fossa where the head of the humerus gets articulated to form the shoulder joint. The medial border is the vertebral border. I'm talking about the posterior surface here. The medial border is the vertebral border and we have a superior border. Simple, lateral border, medial border, superior border. Then we have two surfaces. One is the posterior surface, the other is the anterior surface. Imagine that this is the scapula, the one is this the posterior surface and this is the anterior surface. The anterior surface is actually in contact, or I would say it is actually facing the ribs. So it is also called as the costal surface. It is also called as the costal surface. Then my scapula is going to have three angles. superior, inferior, and lateral angle. Superior, inferior, and lateral angle. And the body is actually divided into two surfaces by spine of the scapula. Look at the spine of the scapula, guys. So this is it's not properly seen here. The spine of the scapula divides the scapula into supraspinous fossa and infraspinous fossa. Look at it. This is the spine of the scapula, which is dividing it into supraspinous fossa and infraspinous fossa. Next, the anterior or the costal surface is called as the subscapular fossa. It's the surface for the attachment of the subscapularis muscle, right? The anterior surface. If you imagine my hand to be the scapula, this is the anterior surface and this is the posterior surface. The anterior surface is also called as the costal surface and is the surface for the attachment of subscapularis muscle. Whereas if you look at the posterior surface is divided into supraspinous and infraspinous area by the spine. There is a spine which runs like this and divides it into supraspinous fossa and infraspinous fossa. No points for guessing. Supraspinous fossa gives attachment to supraspinatus muscle. Infraspinous fossa gives attachment to infraspinatal muscle. Now, we have already sorted out three muscles: supraspinatus, infraspinatus, and subscapularis muscle. Three muscles we have sorted out, three borders we have sorted out, three angles we have sorted out on two surfaces. Next, let's go to the three processes of scapula. We have number one, acromion process. Number two, we have the coracoid process. Number three, we have spine of the scapula, neck of the scapula, right? In your practical examinations, you will be asked to identify any of these processes, right? They'll just give this bone to you and they'll ask you to identify the acromial process, or they'll just give you this bone and ask you to identify the coracoid process. Once you identify this to be the coracoid process, then they'll ask you what is the importance of coracoid process, or they may ask you what joint it forms, or they may ask which muscle the attachment it gives rise to. So the possibilities are endless in osteology, right? They can go anywhere. So that is why, as I said, be mentally prepared to pick that one bone that you're confident about. You have to pick up that bone only when you go to your examination. Otherwise, the possibilities are endless in osteology. By mistake, if you say, let us say, coracoid process, then they'll ask about, okay, which muscle does it give rise to? You say coracobrachialis. Then they can go ask which is that nerve that pierces that muscle. Then you say musculocutaneous. See, they can then go to, through musculocutaneous nerve, they can then go to brachial plexus. So questions can go from anywhere to anywhere. So that is why pick up that bone that you are extremely comfortable answering questions with, right? So this is the posterior aspect of scapula. You can see the glenoidal cavity. This is the acromion process. This is the coracoid process, superior border. This is the medial or the vertebral border. And this scapula is actually, it belongs to left side. This scapula belongs to left side. As you can see, laterally, glenoid cavity is always placed laterally, right? If the glenoidal labrum is pointing towards the lateral side, then it is my left-sided scapula. Then look at this. Look at this. All of the parts of the scapula is very important, and they may pinpoint at any of this and ask you to name that particular structure. So as you can see here, this is the acromial process. This is the coracoid process. This is the scapular notch. This is the superior border. Neck of the scapula, lateral border. This is the medial border. Now look at this. This is the glenoidal labrum. As you can see clearly, it is sort of indented to accommodate the head of the humerus. Then you have the glenoidal. This is the lateral border. This is the medial border. Then if you look at this, the posterior aspect, this is the glenoid cavity. This is the spine, infraspinous fossa, lateral border, acromion process, coracoid process, and supraspinous fossa, and so on. So this image is extremely important, and parts can be asked. Parts can be asked for you to identify. Then articulations of scapula. Number one, it forms the glenohumeral joint. Glenohumeral joint. Gleno meaning glenoidal cavity, glenoidal fossa. Humeral meaning humeral head. So it is between the glenoid fossa of scapula and the head of the humerus. Then we have another acromioclavicular joint. Acromio meaning the acromion process of scapula, clavicle meaning the clavicle. So we have two articulations, glenohumeral, acromioclavicular joint. Right. Next, this is a very important uh, clinical correlation when it comes to scapula, which is the winging of scapula. Imagine, guys, imagine we have a muscle which is called as serratus anterior. It originates from the first to eighth rib and it attaches on the costal surface of the scapula. Imagine my hand to be the scapula. Now, this is serratus anterior muscle which is getting attached from the first eight ribs. This is scapula. Imagine we have the rib gauge like this: 1, 2, 3, 4, 5, 6, 7, 8 ribs we have. From the ribs, this muscle fibers, they come and they get attached on the costal surface of the scapula like this, right? They're attached to the scapula like this. When these muscles contract, it pulls the scapula forward, right? Something is attached here and when it contracts, obviously what happens? It's going to pull the scapula forwards towards the costal surface, right? When it pulls the scapula towards the costal surface, obviously there has to be something attached over here that pulls the scapula from behind also to keep the scapula in position. Imagine if the serratus anterior was continuously pulling the scapula and it would go and hit the rib cage, right? It's not happening. Even when the muscle contracts, the scapula is not going and hitting the rib cage. Why does it not happen? Because we have counterbalancing of the muscles which are there on the posterior surface. So this balancing and counterbalancing is what keeps the scapula in position. Now, this serratus anterior muscle is supplied by long thoracic nerve. Long thoracic nerve, if it gets damaged, now what happens, guys? The pull of the scapula anteriorly is completely gone. In the last class also I told you, whenever there is any nerve injury, it results in the paralysis of the muscle that it is supplying. What is paralysis? Loss of function of that muscle. Initially, serratus anterior was holding my scapula and it was pulling forward. Now, serratus anterior is not able to do that. Why? Because the nerve which was supplying it is injured. There's no input to the muscle. What happens? Serratus anterior gives up. It cannot pull the muscle forward. If it cannot pull the muscle forward, but we already have some guys here who are pulling the muscle back, pulling the scapula backward, those muscles are not injured, those muscles are working properly. What happens when there is no anterior pull, but there is a posterior pull of scapula? Then that results in something called as winging of scapula, where you can see the medial border of the scapula becomes unduly prominent. The medial border of the scapula has become now unduly prominent. Why? Because the anterior pull is gone. Na? The anterior pull, which was coming from the serratus anterior, is completely gone. So, winging of scapula is a condition in which the medial border of the scapula protrudes out of the back. Undue protrusion of the scapula, medial border of the scapula, when pushing with the arm. Why? Because there is injury to the long thoracic nerve that innervates the serratus anterior muscle. Serratus anterior muscle. Now, how can the long thoracic nerve be damaged? It can be damaged to trauma to shoulder, repetitive movements involving the shoulder, or by something, maybe there is some structure which is pressing on the nerve and so on and so forth. There could be a trauma, there could be anything, right? Whenever this nerve, long thoracic nerve, is actually injured, that results in winging of scapula. And what is that winging? When I try to push against a wall like this, my medial border, the medial border of the scapula becomes prominent. Why? My serratus anterior muscle is gone. Serratus meaning serrations. The muscles actually come and get attached like this, right? In the costal surface, subscapularis muscle is there, and also we have serratus anterior muscle coming from the first to eight ribs. Very, very important clinical correlation to scapula. This is a short question, right? You will get this ask this question in some or the other way, either in your theory or in practicals, or as a 3-marker question. Even muscle is important, nerve supply is important, and why it happens you should be knowing. That's it. Scapula sorted. Scapula, very important. Number one, identification. Glenoidal, first identify anterior posterior surface. Once it is very easy to identify anterior posterior because posteriorly you see the spine, right? I don't have a bone with me. But then once you identify, hold the bone like this and see where the glenoidal cavity is pointing towards. If the glenoidal cavity is going laterally, glenoidal cavity is always laterally. If it is pointing towards the right side, then it is right. If it is pointing towards left side, then it is left. As simple as this. Okay, imagine holding the bone like this. Imagine a patient is standing in front of you and then decide whether it is right or left. Easy, you cannot get this scapula. Nobody gets it wrong. Okay, it's quite easy to identify both sides as well as the bone. Right. Next we have clavicle. Clavicle is the only long bone which is horizontal, right? Clavicle is the only long bone which is horizontal and that lies in the root of the neck. Clavicle has some important functions. Number one, it helps to transmit the forces from upper limb to the bones on the axial skeleton, that is my sternum. For example, I'll just give you an example. When you lift something, right? When you are lifting you're doing biceps curls or you're trying to lift a bucket of water, you're actually exerting a lot of force, right? You're exerting a lot of force. And where is that force going? That force eventually gets transmitted onto your axial skeleton, which absorbs that force. Otherwise, the bones will break, right? Once you pick up the bone, that will actually transmit the force into your axial skeleton. And what is that bone that transmits the force from appendicular to axial skeleton? Clavicle, right? So clavicle, first point, it's the only long horizontal bone. It's the only long bone which is horizontal. Second, its important function is to transmit the forces of upper limb to the axial skeleton. Then third point, it acts as a strut holding the arm free from the trunk. Your arms are free, right? Your arms, you can do any movement. How is it possible, right? It is because of clavicle. And it also protects the neurovascular bundle. In the next class, we'll actually be talking about brachial plexus and everything. So it clavicle actually protects this and does not expose it to any sort of injuries even in case of trauma, right? As I said, it is a long bone. It is a long bone with two ends. There is a medial end and a lateral end. You can see that this is the medial end. It's some sort of a S-shaped bone, right? You can see it is kind of an S-shaped bone where it has a medial end, which is the sternal end, and the lateral end, which is the acromial end. Acromial end, obviously, it where does it go? It articulates with the acromial process of scapula, and sternal end articulate with the manubrium of the sternum to form the sternoclavicular joint. And this, on the lateral side, it forms the acromioclavicular joint. Now, the shaft, or this is called as the body, which has a medial 2/3 and that is convex, and the lateral 1/3 which is concave. Concave. So this is the convex part and this is the concave part. You can see this is the medial end which is convex, this is the lateral end which is concave. Then muscle attachments. Clavicle has many important muscle attachments, out of which there's one important muscle which is my sternocleidomastoid, and we have the pectoralis major muscle. You can see pectoralis major muscle. Then we also have trapezius. We also have trapezius, which is trapezius gets inserted. See, trapezius is this muscle, right? It's a fan shaped muscle which comes like this and it gets attached in the. It has wide range of attachments. Like it gets attached to so many bones. It's attached to clavicle as well. Then of course we have subclavius muscle in the subclavian groove. They hammer you this in your anatomy classes. In the clavicle there is a subclavian groove where we have a subclavius muscle. So you cannot get these questions wrong. So what are the different muscle attachments that we have in clavicle? All of these are very important muscles, guys. All these muscles are very important. Injury to these muscles or any fracture to clavicle will result in different consequences. So first muscle which takes origin is the sternocleidomastoid. Then the name only says, right, sternocleidomastoid. Sterno meaning it takes its origin from sternum. Cleido meaning it takes its origin from clavicle as well. Finally, it goes and gets attached into the mastoid process. Then we have the coracoclavicular ligaments, which are the conoid and trapezoid joining to the coracoid process, conoid and trapezoid tubercles of clavicle. So Look at this, guys. We have so many, all of these muscles are extremely important: sternocleidomastoid and pectoralis major. And we also have the deltoid muscle that takes its origin. Deltoid muscle, just a quick question. Deltoid muscle is supplied by very, very important nerve. Yesterday we did in the last class. Injury to that nerve results in what kind of paralysis? Number 1 point. More importantly, what sensory supply is lost if that nerve is injured? Deltoid is the question for you guys. Just go back, see the previous class, you'll get the answer. The nerve supply to deltoid, first question. Second, if that nerve is injured, what happens? What is the sensory loss that I am talking about? Okay, these are the two important questions pertaining to deltoid. Then we also have some important ligaments like trapezoid ligament, conoid ligament, and costoclavicular ligament. But origin of these muscles is extremely, extremely important. You cannot get this wrong, right? Then what is the clinical importance? See, the fracture of clavicle is very common at the junction between the middle and lateral one third. Any form of indirect force, like for example, this area is what is prone for fracture, right? The medial fragment becomes more prominent and elevated by the sternocleidomastoid, whereas the lateral fragment sags down because of the weight of the arm. Why? See, sternocleidomastoid is a muscle that is actually going upwards like this, right? Sternocleidomastoid is going upwards like this. Whenever there is an injury, whenever there is a fracture somewhere here, this muscle which is going upwards tilts the clavicle. It pulls the clavicle and pulls the medial side upwards. Now look at this, guys. What is there on the lateral side? Lateral side, I have the shoulder joint. When shoulder joint meaning all the other bones of my upper arm like humerus, radius, and ulna, because of the weight of the upper limb, upper bones of the upper limb, this the lateral side tilts downwards, whereas the medial side goes upwards. So this is what happens in case of fracture, clavicular fracture. This is a very common presentation when you start go to your internship. When you see fractures, this is a very common presentation that you see. So fracture of clavicle is very common at the junction of middle and the lateral one third. And then the lateral fragment sags down, whereas the medial fragment goes up because of it is elevated by the sternocleidomastoid. Sternocleidomastoid. Yes. Then next, very, very, very important bone, guys, humerus. Humerus, you should probably know everything about humerus. Okay, you cannot get any questions on humerus wrong. It's very, very important. Number one. First point, it's the long bone of upper limb which extends from shoulder to elbow. Right, no doubts in that. Then it's a tubular long bone which is composed of two ends, upper end and shaft, and the lower end. Right. Now let's come to the upper end of humerus. The upper end of humerus consists of head, neck, and tubercles. I have a head, I have neck, and tubercles. We have two different necks. That is, one is my anatomical neck and surgical neck. Only difference is surgical neck is more prone for injury, and whereas the anatomical neck is the narrowest region in the trabeculus. That's all you need to know about it. Nothing is very important. But surgical neck is of my, it is of clinical importance to me. Again, one more question for you guys. Which is the nerve that gets injured when there is a fracture to the surgical neck of humerus? This is a question. Which nerve gets injured and which artery gets injured when there is a fracture to the surgical neck of humerus? This we covered in last class. You will tell me the answer in the next class. Okay? Yeah. So basically, my upper end of humerus has a head, it has greater tubercle, it has lesser tubercle, anatomical neck, and surgical neck. And in between the tubercles, we have an intertubercular sulcus. You can see some sulcus kind of a thing running here. That's called as intertubercular sulcus. It's also called as bicipital groove. Then the lower end consists of two epicondyles, two processes, three fossae. Two epicondyles lateral and medial, trochlea and capitulum, and three fossae. Then the shaft is kind of a prismatic cylindrical above, and it becomes like a prism below, and it contains of three borders, three surfaces, and the proximal aspect of the humerus articulates with the glenoid fossa of the scapula forming the glenohumeral joint, which we already covered. And distally at the elbow joint, it articulates with the head of the radius and the trochlear notch of ulna to form the elbow joint. So now it has three borders and three surfaces in the shaft, and it basically the upper end articulates to form the shoulder joint and the lower end articulates to form the elbow joint. Then this is what is very, very important, guys. You will be given the bone humerus. You will be first asked to identify the bone, second asked to identify the side it belongs to. Then they will definitely ask you to identify where is greater tubercle, where is lesser tubercle, and what are the muscles attached, and what is there in the intertubercular sulcus. Every word that I speak here is important for your practical examinations. Now, proximal humerus, as I said, there is head, anatomical neck, surgical neck, greater and lesser tubercles, and bicipital groove, which is my intertubercular sulcus. I hope there is no doubt in this. Next, the upper end of humerus, it consists of head which faces medially, have a correlation. I had my scapula whose glenoidal labrum, glenoidal cavity was facing laterally, and the head obviously has to face medially, right? If imagine that my hand to be the scapula, and in which this is the lateral surface and this is the medial surface, and my head of the humerus is facing this way, right? The glenoidal labrum is facing towards lateral side, whereas the head of the humerus is facing towards the medial side. Very important, guys. The head always faces medially, and it goes upwards and backwards, and is separated from the greater and the lesser tubercles by the anatomical neck. Okay, next comes the greater tubercle. I'm talking about this area now. This big structure is my greater tubercle. Greater tubercle is located laterally, right? Greater tubercle is located laterally, and it is a bigger of the two tubercles, and it has anterior and posterior surfaces. Now, very, very important, greater tubercle gives rise to the attachment of three rotator cuff muscles, which are my supraspinatus, infraspinatus, teres minor. All three muscles are coming from scapula. I've already told you about supra and infraspinatus. Remember, scapula was there like this. Posterior surface, there was a spine running, dividing into infraspinous and supraspinous fossae. From the supraspinous fossae, we had supraspinatus. Below, we had infraspinatus. And teres minor comes from the lateral surface. Okay, so all three rotator cuff muscles, supraspinatus, infraspinatus, and teres minor, gets its origin from scapula, and it's inserted into the greater tubercle of humerus. Get this imprinted in brain. Next, they attach to superior, middle, and inferior facets respectively on the greater tubercle. Greater tubercle, important points. Number one, it is bigger compared to greater and lesser tubercle. Greater tubercle is bigger. Number two identification point, it is lateral. Number three important point, it gives an attachment site to supraspinatus, infraspinatus, teres minor. It's also called as sit muscles. They're also called as sit muscles. SIT. What are those muscles? They are rotatory cuff muscles. Applied aspect, whenever there is a rotator cuff injury, it results in the injury to these muscles. Rotator cuff injury is very common. Next, lesser tubercle is a smaller, and it is more medially located on the bone. It has only one surface. It provides attachment to the last rotator cuff muscle, which is subscapularis. Where was subscapularis coming from? Subscapularis was coming from the costal surface of the scapula, right? It was coming from the costal surface of the scapula. All four muscles, rotator cuff muscles, sit muscles plus subscapularis muscle, where is it coming from? It's coming from the scapula. It is getting inserted into the greater and the lesser tubercle of humerus. Imagine, guys, if this is my shoulder joint, all of these muscles are crossing the shoulder joint and getting attached onto the surfaces. So it is in a way strengthening my shoulder joint. All the rotator cuff muscles, they strengthen my shoulder joint. Right. Now, separating the two tubercles is a deep groove, which is known as the intertubercular sulcus, right? Now, it's the area of passage of important tendon. There is a long head of biceps brachii, which emerges from the shoulder joint, and also it gives I mean, it is basically like here one side you have greater tubercle and the side you have the lesser tubercle. It is like a valley which is running in between them, and those two sides of the valley are called as lips. This gives attachment to pectoralis major, teres major, and latissimus dorsi, which insert on the lips of the intertubercular sulcus. Three muscles: pectoralis major, teres major, and latissimus dorsi, they insert on the lips of the intertubercular sulcus. This is also called as lady between two majors. Lady between two majors. What are the two muscles? Three muscles in the intertubercular sulcus: pectoralis major, teres major, and latissimus dorsi. Latissimus dorsi. Okay. Now look at this. Look at this, guys. This is a beautiful diagram depicting where the muscles are. You can see the SIT muscles here: supraspinatus, infraspinatus, and teres minor. You can see the subscapularis here, and you can also see the bicipital groove and the muscles attached. Latissimus dorsi, teres major, and pectoralis major. That's it about the head of the humerus. Head of the humerus, very, very important, guys. 100% a question will be asked in your practical examinations, right? In head of the humerus, again, I'm just revising. What are the parts of head of the humerus? We have head, two tubercles, intertubercular sulcus, surgical neck, anatomical neck. Talking about surgical neck, what are the things that we are supposed to know? Nerve and the artery injured in the fracture of the surgical neck of humerus. Number two, muscles attached to greater and lesser tubercles. Number three, identification of greater and lesser tubercles and the intertubercular sulcus, also called as lady between muscles attached to the lady between the two majors, latissimus dorsi, pectoralis, and teres major. Understood? I hope there is no doubt here. Then the surgical neck actually runs from distal to the tubercles of the shaft of the humerus. The axillary nerve and the circumflex humeral vessels lie against the bone here. So the previous question that I asked, what happens when there is a fracture to the surgical neck? I said this area is of practical importance to me. Why? Because if there's any injury to surgical neck, results in the axillary nerve or the circumflex humeral artery damage. Okay. Next, in the shaft, what are the different things that we have? Guys, in the shaft, we have a very important landmark called as deltoid tuberosity, where the deltoid muscle attaches. Where was deltoid muscle coming from? It was coming from clavicle. Where is it getting inserted? It is getting inserted in the deltoid tuberosity of the humeral shaft. Understood? We are sorting out so many muscles here, without you even understanding, we are sorting out so many muscles, right? At the end of this class, just go back to your books, open your book, and start writing each and every muscle that we discussed today. Where is it taking its origin from? Where is it getting inserted? And what is the nerve supply? This will kind of give you a complete orientation about upper limb muscles. Okay. Today's homework is going to be opening our books and knowing what are the different muscles that we sorted out today and where are they coming from, where are they getting inserted. All right. Very important. Then we also have something called as radial groove, which we already discussed in the previous class, which is a shallow kind of a depression in the posterior surface of the humerus that runs diagonally and parallel to the deltoid tuberosity, and radial nerve and the profunda brachii artery lie in this groove. In the deltoid tuberosity, we have deltoid. In the in the spiral groove, we have the radial nerve and the profunda brachii artery, right? Next, different muscles get attached into the shaft of the humerus. Anteriorly, we have already sorted out deltoid. We also have coracobrachialis, brachialis, and brachioradialis. Posteriorly, medial and the lateral heads of triceps. Again, don't ever memorize this, guys. See, what is there posteriorly? We have posteriorly the radial nerve, right? What is radial nerve supplies which muscles? Triceps. We have medial and the lateral heads of triceps in the posterior area. Anteriorly, we already have a deltoid tuberosity, so we obviously have deltoid. Now, what are the other muscles that are there in upper limb? We have coracobrachialis, brachialis, and brachioradialis, and so on, right? Don't memorize this. Apply logic. It's quite logical. Don't ever memorize this. All right. Then, in the distal region, let's come a little lower down. We have sorted out what are different structures. We sorted out the upper end of the humerus. We also sorted out the shaft. Then come to the lower end, that is the distal region. Distal region has two borders which form the medial and the lateral supraepicondylar ridges, right? And distal to the supraepicondylar ridges are the capsular projections called as the lateral and the medial epicondyles, right? These are the lateral and the medial epicondyles. You can easily palpate yours, right? They can be palpated at the elbow. The medial is the more prominent one. You can see for yourself. Then the ulnar nerve passes in the groove on the posterior aspect of the medial epicondyle where it is actually palpable. See, this is the overall picture. This is the posterior aspect and this is the anterior aspect. Anteriorly, we have the deltoid tuberosity. Posterior, we have the radial nerve. And then, of course, anteriorly, you can see the lateral epicondyle, medial epicondyle, which is more prominent, and two processes that I already said, which is the capitulum and the trochlea and its medial edge and the olecranon fossa. Then look at the different attachments here now, which we already spoke. Just for the diagrammic, just for the representation in the form of a diagram. So sits muscles are here. Then in the lesser tubercle, we have the subscapularis and the lady between two major muscles in the intertubercular sulcus. These are the medial and the medial head of the triceps brachii, whereas the lateral head of the triceps brachii is here. Lateral and the medial head of triceps brachii is here in the posterior aspect. You also have the big brachialis muscle here, coracobrachialis muscle, and deltoid. Okay, deltoid, brachioradialis, and extensor carpi radialis longus, which comes here. But look at it. Big medial head of triceps and the lateral head of triceps in the posterior aspect. There's a radial groove, radial nerve crosses over like this, and it ends up supplying these two muscles. And also we have a little bit of deltoid and brachialis in the posterior aspect. Then distally, trochlea is actually located medially and like extends onto the posterior aspect of the bone. But lateral to trochlea is the capitulum, which actually articulates with the radius. What part of humerus articulates with the radius? That is the capitulum. Then there are other depressions in the the distal end of the humerus, which are the coronoid process. Guys, this is coronoid process, not coracoid process. Coracoid process was in scapula, remember? And then radial and the olecranon fossae, they accommodate different forearm bones during flexion and extension, because we do such complex movements in the upper limb. The god has given all of these areas to accommodate these movements. Okay, next we have two forearm bones, ulna and radius. Quickly we'll finish them as well. Ulna is the long bone in the forearm with two ends and a shaft. The head of ulna lies distally, head of radius lies proximally. Get this imprinted in the brain. Head of ulna lies distally, somewhere near the carpal bones. Head of radius actually articulates with the elbow joint. Okay. Next, ulna is the medial bone which lies parallel to the radius. Again, never make this silly mistake in your practical examination. Ulna is the medial bone, whereas the radius is the lateral bone, right? Then ulna acts as a stabilizing bone with the radius pivoting to produce the movement. Upper end consists of two processes, olecranon and the coronoid process, and the trochlear notch. The shaft has three surfaces and three borders. The lateral border is introitious and it is sharp, whereas on the other side, the medial border of the radius is introitious and it is sharp. Right? Lower end consists of head and the styloid process. Proximally, it articulates with the humerus. Distally, it articulates with the radius, forming a distal radioulnar joint. Next, proximal osteology and articulation. Here, the upper end of ulna articulates with trochlea, and the important landmarks of proximal ulna are the olecranon process, coronoid process, trochlear notch, radial notch, and the tuberosity of ulna. Right? Olecranon is a large projection of the bone that extends proximally, and it also forms a part of the trochlear notch, and it can actually be palpated as a tip of the elbow, and the triceps brachii gets attached onto the surface of olecranon. Right? So this is the diagram where you can see the anterior and the posterior views of radius and ulna. As you can see, the head of the radius getting articulated here, and here you can see the head of the ulna and the styloid process. This is styloid process of the radius, anterior surface. You can clearly see. Then look at this. This is the upper end of ulna. Anteriorly, if you hold the ulna bone like this, it looks like this. This is the olecranon process, and this is the coronoid process, and this is the trochlear notch. This is the radial notch. Radial notch is for the radial head. Trochlear notch is for trochlea of the humerus. Coronoid process is a ridge of bones, and what comes there? We actually have the triceps brachii. Trochlear notch is for the is actually for the trochlea of humerus. Radial notch for the head of the humerus. Tuberosity of ulna is where the brachialis muscle comes and gets attached. Okay, look at this. Just another diagram showing it. Shaft of the ulna has three borders and three surfaces, and anterior, posterior, and medial surface. You have lot of muscles, but the important landmark over there, one you have to remember, is the anteriorly it gives a site of attachment for the pronator quadratus muscle, and you have three borders: posterior, lateral border is the introitious border, and there is a sharper border, right? And the anterior borders are posterior, lateral, and anterior. Anterior, posterior, and medial surfaces are there. One important landmark over there is for the pronator quadratus muscle. See, all of these muscles, I mean, this in itself is a topic for 1 hour if I go on describing the different muscles attached. Just know for pronator quadratus, we have a, you can actually see the, for the attachment of pronator quadratus muscle on the anterior surface. Then distally we have ulnar head as well as the styloid process. Head articulates with the ulnar notch of the radius to form the distal radio-ulnar joint. Ulna is a quite a simple bone. It's very easy to identify. There's no way you will go wrong in identifying the ulna. Okay. There are two fractures related to radius and ulna. Montagia fracture and Galeazzi fracture. Remember Montagia, whenever you hear the word Montagia, remember the name Umesh. Okay, remember the name Umesh, in which it is usually caused by any force from behind the ulna, and there is proximal ulna is fracture and head of the radius is dislocated anteriorly. Okay, how do we remember this? Umesh, right? U is ulna is what is damaged. Okay, ulna is actually what is damaged, and what is that? It is the shaft of the ulna is damaged, medial bone, sh meaning shaft. Okay, ulna is the bone which is damaged in Montagia fracture, sh meaning shaft. So this is how you remember: ulna bone injured in Montagia fracture, shaft of ulna is injured in distal head of the radius dislocates anteriorly. Whereas the opposite of that is the Galeazzi fracture, in which there is a fracture to the distal radius where there is ulnar head dislocation. Okay, they're opposite, right? A fracture of ulna resulting in the fracture of the shaft of ulna, and radial head dislocation is Umesh, right? Ulna muscle, ulna bone, Montagia fracture, shaft of ulna is gone, and radial head is gone. Galeazzi, it fractured to the radius with ulnar head dislocation. Okay, ulnar head dislocation. Two opposite fractures clinically relevant. Then we have last 5 minutes will take for radius. Radius is again a long bone that consists of the upper and the lower end and shaft. Right. Upper end consists of head. Head I've already told you articulates with the capitulum of humerus. Lateral surface with radial notch of the ulna, which goes and articulates with ulna. Neck is the constricted part below the head, and there is a radial tuberosity below the medial part of the neck. Shaft consists of three borders and three surfaces. Not very important. Now look at it. This is the right-sided radius and ulna, anterior and the posterior aspect. Same image that I had shown earlier, and it gives rise to all of these muscles, which I don't have time to explain right now. Okay, this is the humerus, this is the ulna, this is the radius. You can see how beautifully they are articulating with each other. Radial head, and then you can see the trochlea, olecranon process, and all of this. Right now, this is how radius looks. Radius is kind of slim in the proximal part, and it becomes widened, and it becomes widened in the distal end. It has a In the distal end, it has styloid process and an ulnar notch. In the proximal part, it has a head, neck, and the tuberosity. It has introitious border and the anterior surface and the posterior surface. Quite simple, guys, nothing complicated in this. And you will be asked to pick up this bone as well to identify. Okay. Now, the distal end consists of 5 surfaces, which we already studied, and a styloid process. Styloid process is present in both radius as well as in ulna. Okay. Next, the shaft of the radius is triangular, and in the middle of the lateral surface, there is a small roughening for the attachment of pronator teres muscle. Similarly, we had a similar thing in ulna also for pronator quadratus. Pronator quadratus comes from ulna. Pronator teres comes from radius. Teres, R is coming, right? Teres, res meaning comes from the radius. Okay. In the distal region of the radius, we have a styloid process and we have a concavity called as the ulnar notch, and which articulates with the head of the ulna, forming the distal radioulnar joint. And also, more importantly, the distal surface of the radius has 2 facets for the articulation with the scaphoid and lunate carpal bones. That makes up the wrist joint. Okay, look at this beautiful pictures again, showing different parts, ulna, and how the articulation is actually taking place. And you can see the introitious borders and introitious membranes. And then look at it. This is radius, which is actually going and articulating with scaphoid and lunate. There's an articular disc here. This is the triquetrum, and this is ulna. And you can see the ulnar styloid process here. Next, clinical correlation, guys. We have something called as Colles fracture and Smith's fracture. Colles fracture results in dinner fork deformity. It basically, Colles fracture happens when you fall and you twist your hand like this. It's called as foosh, falling on outstretched hand. When you fall on your outstretched hand, it results in Colles fracture, which results in dinner fork deformity. There's another fracture called as Smith's fracture. When you fall like this, right? When, let's say, you fall from your bike and your hand gets twisted like this, there's a result in Smith's fracture, which causes garden spade kind of deformity. Very important clinical correlates. Last, carpal, metacarpals, and phalanges. Now, look at it, guys. So there are 8 carpal bones: scaphoid, lunate, triquetral, pisiform, capitate, trapezium, trapezoid, capitate, and hamate. And what is the world famous mnemonic for this? She looks too pretty, try to catch her. Simple, nothing really, well, I mean, nothing complicated here. And we have 5 metacarpal bones and 14 phalanges. Okay, these are the carpal bones, 8 bones, irregularly shaped bones arranged in 2 rows, proximal and distal. Proximally, we have she looks too pretty, scaphoid, lunate, triquetrum, and pisiform. Distally, try to catch her, trapezium, trapezoid, capitate, and hamate. Simple, right? Look at the bones, look at the bones. And each bone is named according to its structure. Lunate apparently looks like a moon, and then you have trapezium, which looks like a trapezium. There's a pisiform bone, and then totally we have 8 bones here, right? Then last and very important topic is the peculiarities of pisiform, right? See, every bone is covered by something called as periosteum. Go back to your general anatomy where you understand the structure of a bone. Every bone is covered with periosteum. Now, periosteum provides nutrition to the bone. If suppose if a bone does not have a periosteum, how do you think it's going to get its nutrition from? Those bones which do not have a periosteal membrane and they actually grow in some muscle is what is called as a sesamoid bone. And pisiform is a sesamoid bone with no covering of periosteum. Okay, it does not have any covering of periosteum. It's the smallest carpal bone. It's a P-shaped bone embedded in the flexor carpi ulnaris tendon. It's embedded in the flexor carpi ulnaris tendon. And another point to remember, it is the bone that ossify last. If you see pisiform bone in X-ray, that means the age of that person is definitely more than 60. Okay, this is the last bone that ossifies out of all the carpal bones, which you will study, which is of importance in forensic examination. So, what are the peculiarities of pisiform? Number 1, it's a sesamoid bone. Number 2, there is no covering of periosteum. Number 3, smallest carpal bone. Number 4, it gets embedded in the flexor carpi ulnaris tendon. Number 5, it ossifies last in the carpal bones. Ossify last in the carpal bones. Yes. So that ends up today's session on osteology. As I keep repeating, let's take some poll questions towards the end so that we'll see how many questions did we actually understand and did we actually get. So yes, let's launch the poll. Now, which muscle does not insert in or next to the intertubercular groove in the upper humerus, right? So what do we have in the intertubercular sulcus? We have, how many muscles do we have? We have three muscles. What are the three muscles? Lady between two majors. So we have pectoralis major, yes. Do we have latissimus dorsi? Yes. Do we have teres major? Yes. So which is that one muscle that we don't have? Pectoralis minor. Where is pectoralis minor? It's a question for you. You will tell me in the next class where the pectoralis minor is coming from and where it is getting attached. Okay? Yes. Let's take just one more question to see if we have understood the concepts or not. Which of the following muscles does not insert into the scapula? Right. Number one, we have trapezius. Number two, we have levator scapulae. Number three, we have pectoralis major. Number four, rhomboids, and all of the above. The answer is pectoralis major. Pectoralis major is not a muscle which goes into the posterior aspect, right? Pectoralis muscle is not the muscle that goes into the posterior aspect. Okay, so out of these two questions, I'm quite sure that you've understood the concept. And as I keep repeating, this is an important practical questions for you. All the questions that I've covered today are very important for your practical examinations, and pick the one that you are comfortable with. Don't go and pick something that you're not comfortable and you'll flunk in your examinations. Okay, and if you have any doubt, do make sure to follow us in on all our social media handles. And if you have any doubt, you can reach out to us through any of this. And I hope that you have found my class useful today, and stick to the schedule, and I'll make sure that you learn upper limb quite well towards the end of this month. And thank you so much for staying so long, and I wish you all the very best, and good night. Thank you.